So thank you all for joining us this evening. My name is Brooke Doucet. I will be the moderator for today's webinar. Currently, I am employed at Ochsner Lafayette General Medical Center in Lafayette, Louisiana, as a bariatric coordinator. I am a registered nurse of 24 years with 18 years of bariatric experience. I also chair the Integrated Health Multidisciplinary Care Committee, and I also serve as a committee member for the past 8 years. And it's been very rewarding as we continue to develop and implement projects to impact education, communication, research, and many other areas of obesity treatment. I have the pleasure of introducing our 3 presenters today. Their passion and commitment to serve the bariatric population is evident by the multiple positions and awards that they all have received. So the presenters have no relevant financial interest or other relationship with the manufacturers of any commercial product and or provider or commercial services that are discussed in this webinar. So our first presenter for today is going to be Dr. Nicole Franklin. She is a board certified clinical health psychologist and the assistant medical director at the McLaurin Bariatric and Metabolic Institute in Flint, Michigan. Alongside her clinical responsibilities, she also leads the Diversity, Equity, and Inclusion Committee at McLaurin Flint and has served in the United States Air Force. Currently, she is affiliated with the Department of Psychiatry at the Michigan State University's College of Human Medicine as clinical faculty, and she's also the co-chair of the Interdisciplinary Health Committee at ASMBS. Dr. Franklin's commitment to serve over the years has garnered her recognition, earning her prestigious awards such as the International Awareness and Involvement Women of Achievement Award from Delta Sigma, the sorority's Flint Alumni Chapter, the Corporate Women of Achievement Award from YWCA and McLaurin Regional Medical Center. And she's also from the Wright State University School of Professional Psychology and the Good Conduct Media from the United States Air Force. The second presenter will be Janée Tyus. She holds a Bachelor of Science degree from the University of Michigan and Ann Arbor and a Master of Public Health from the Drexel University School of Public Health. Janée serves as a Senior Program Director of the Mid-Michigan Community Health Assessment Program of the Greater Flint Coalition and as the adjacent lecturer at the University of Michigan, Flint. Her passion for people, the underserved, and the health is a solid foundation and guiding light in her work. She has extensive experience operating, implementing public health programs in the nonprofit sector. She recently served as the co-chair of the Michigan Department of Health and Human Services Community Information Exchange Task Force from 2022 to 2023. She was appointed to serve on the Michigan Department of Health and Human Services, Health Information Technology Commission, and chairs the Community Information Exchange Advisory Council. Janée was born and raised in Detroit, Michigan, and currently resides in Oakland County, Michigan, with her 2 Sharky puppies. And then our third presenter today will be Ms. Casey Flowers. So Casey is a registered dietitian and a board-certified diabetes care and education specialist with a master's degree in clinical nutrition from the University of Michigan. She began her career in the intensive care unit before focusing on outpatient weight management in bariatric medicine. In Nashville, as a program dietitian, she enhanced patient outcomes from program development and social media initiatives. Passionate about health equity, Casey joined Morehouse Healthcare in Atlanta, Georgia, where she teaches plant-based nutrition and weight management to students and the community. An active member of the Academy of Nutrition and Dietetics, she contributes to the weight management practice group, serves on the nominating committee, and has appeared on local news channels. Currently, she is serving on the education committee of the Georgia ASMBS chapter. Casey co-directed the ASMBS 2022 and 2023 nutrition course. She was honored with the Excellence in Nutrition Award at the ASMBS 2023 National Conference in Las Vegas. In her spare time, she enjoys cheering on the Atlanta Falcons and checking off her next national park destination. So thank you.
Hello, I'm going to get things started. I am so grateful that you guys have joined us today. I will apologize in advance. I am dealing with a sore throat, but I am going to do my best to project my voice so that we can get going and get some great information to you guys. If you remember in my presentation, I am an Air Force veteran. And so what you see on our objective page is a picture of the Good Conduct Medal. And what I want to do is associate good conduct with completing these objectives. I want it to be known that we are going to provide the best care to our patients by addressing social determinants of health. In the military, you get a medal when you do something amazing. We don't always get such tangible rewards in healthcare, yet the work we do is quite impactful as well to the patients that we see. So one of the first objectives that we're going to delve into is making sure that we include social determinants of health as part of our case conceptualization. We want to make sure that we are using a holistic approach when we're thinking about how we take care of patients, because we all know a majority of the things that happen regarding patient care don't necessarily happen inside of our office. When we talk about Maslow's hierarchy of needs, a lot of times the things that we're talking about we want patients to achieve are in the self-actualization phase right at the top. Yet a lot of our patients come in and they don't even have the basic needs that they require to get to that point. So addressing these social determinants of health will help us help them build what they need so that they can achieve the goals that they want to achieve. We're also going to talk about collaborating with community partners. We cannot do this alone. And there are a lot of community agencies out there that are doing the groundwork. There are the foot soldiers out there. I use the term boots on the ground often to refer to the work that they do, because they're actually out there in the communities. I'm in a clinic all day. There's no way that I can have the same impact with my patients that these community agencies have. And so we've had the wonderful opportunity to connect with some great groups. We're also going to talk about how to routinely incorporate social determinants of health assessments into what you do every day, and then using that data to change how you provide care. And then lastly, we're going to examine a blueprint that will talk about how we can get money to fund various programs to assist us with dealing with these social determinants of health. Now, Healthy People 2030 is the fifth version of the Healthy People program, and it is the cornerstone of what work is done by Health and Human Services. And they are focused on not only health equity, but health literacy. And in this most recent rendition, it has not just been focused on health literacy of the individual, which we have typically looked at, making sure that our patients are able to understand the information presented to them, but it also puts responsibility on the organization to have a literacy about the type of patients that it is taking care of, to make sure that we're not just putting information out there that is not applicable to the experience of our patients in our communities. It's nice to have a list of things that patients can do, but if they don't have resources in their space to actually act on the recommendations that we make, then our recommendations aren't going to have the impact that we want them to have. So it really is part of the organization's responsibility to make sure that we are working with our patients to determine what they really need. So where did this all start? Because 10, 20 years ago, you didn't hear about health equity as much as you do today. And I have some individuals that are photographed that are very important in this process. And Dr. Satcher was one of a number of professionals who worked to develop a study that looked at some of the disparities he was seeing in healthcare as it related to African Americans at that time. One of the things that he noticed was, one, there wasn't enough providers of color, and two, there was some significant discrepancies in mortality rates for African Americans in particular disease processes. And so what they did was they took this information to, Secretary Heckler, who was the head of the Department of Health and Human Services at that time, and said, hey, what can we do about this? And you know what? She did not ignore them. Not only did she not ignore them, she expanded the way that we look at minority health and developed the first comprehensive look at how we can make changes to our healthcare system to make sure that we take care of everybody. And her report is finally called the Heckler Report. She's amazing. And so what her work did was it started with Healthy People 2000. The goal was to reduce disparities. And as you continue to look at it, you see how it's grown from reducing disparities to eliminating disparities to achieving health equity to now where we're looking at attaining health literacy and well-being for all. Thank you, Secretary Heckler. I mean, she's in another space now, but I am forever grateful for her taking that initiative. And one of her quotes that she said was, our medical system is too advanced for this. We have too many resources available to us in this country to not be able to take care of everybody. And so when you look at how that's evolved, one of the things you will commonly see now is the social determinants of health wheel. And my colleague, Casey, will talk a little bit more about how this relates to obesity specifically, but I just wanted to briefly just talk about the different layers that it looks at, from education to healthcare to where you live to who you spend time with to how much money you have. All of these things are going to play a role in what your healthcare looks like and what you have access to. So we focus on obesity, most of us in our practice. One of the goals that Healthy People 2030 said is we want to reduce those rates. And so at the time, the baseline was at 38.6%. Our target was 36%, but where we're at is 41.8%, which means we're not getting better, it's getting worse. And there are a lot of things that contribute to that. One of the big things that is having an impact, particularly in our state of Michigan, is food deserts. There are so many areas where individuals have to drive more than 20 minutes to get to a grocery store to be able to buy food items. So what tends to happen to a lot of folks in those particular environments, they are grocery shopping at corner stores or at Family Dollar stores. And those stores tend to have products that have a longer shelf life, right? So they're more likely to be prepackaged. They are also likely to spend more money for those same products than if they would have been able to go to a grocery store. The other thing that we're seeing is portion sizes have increasingly gotten larger and larger as we've gone to various, not just fast food restaurants, but family restaurants. And so they're making it very convenient for us to consume things that are not always in our best interest. So from the food deserts to the larger portion sizes to the difficulties folks have with transportation, it's still creating this perfect storm for our obesity rates to continue to increase. So we got to figure out what we can do to make a change and cause a pivot. There are still signs showing that obesity is disproportionately affecting minorities, and there is a significant amount of money being spent to treat this medical condition. What we do at our site is, in order to get a better idea of some of the social determinants of health that are impacting care, we are using this needs screening tool. This tool was developed by our community partners at CHAP, and they're going to talk a little bit later in this presentation. But I wanted to talk about the tool that they created. One, I thought it was very important to have, again, individuals with boots on the ground to create this inventory because they actually know what people need. And they went back at least 12 months so that we would have an idea of what people were dealing with in the last year. The other thing I like about this screening tool is it gives an opportunity for the patient to opt out of us forwarding this information any further. So I often will have people that'll tell me that they're struggling with different things, but right now they don't want any assistance for it because they have other avenues that they are working on to get resources. But it still lets me as a provider know what patients are dealing with so that I can ask appropriate questions and provide, if I have samples or something like that, I can make sure that I target those individuals to make sure that they get what they need. This particular measure is given to all of our patients at the time of their psychological evaluation. We do have another screener that my medical team does. That's about 2 or 3 questions that actually is embedded within our electronic medical record that is asked more routinely. This particular measure is just given to patients once a year. So there are a lot of different things that we look at when we are trying to determine what are some of the social drivers of health. And here are a couple of various websites that you can go to get information specific to the area that you live in. On the next couple of slides, I am going to be specifically looking at the area deprivation index and how that relates to some of the work that MShield has done. MShield is a collaborative quality initiative that has been funded by Blue Cross Blue Shield, Blue Care Network, and Michigan Medicine. They recently pulled together some data and presented at a conference we were at just earlier in June. And they were kind enough to allow me to use their slides to talk about what some of their data looks like. And so Dr. Farban and Dr. Ferguson first took the state of Michigan and looked to see where we were considered deprived. And you will see that the red indicates where we have a lot of deprivation within our state compared to national norms. You'll see right through the middle where you get more blue, that is where we have our auto plants. And so really outside of some of that auto plant work or our major universities, there is really a lot of poverty within our state. When we take it to the next slide, we look at what is happening just within state. So we're looking at the folks that are in the top 10% compared to the lower 10%. And what you see is there's a little bit more variety in regards to where we are seeing the concentration of deprivation, but still in our rural areas, we've got quite a bit of deprivation. And so what they did was they looked to see, in regards to 30-day outcomes, is there a significant difference between these groups? And what they found is with the work that they've been doing with MShield, there wasn't a significant difference in 30-day outcomes. But what we're starting to see clinically is that after those 30 days, there is some change. And what I want to do and work with next is to see what can we do to impact that long-term change? Because my interpretation of these results in the first 30 days, a lot of times patients have saved money to get their protein shakes. They have a stockpile of vitamins. And so when they get through their first batch of stuff, they don't have the resources to refuel or rebuy. And that's when that food insecurity comes in. Now I'm going to pass it on to Casey, who is going to talk a lot about how we help patients past that 30-day window, deal with some of those food insecurities.
Well, thank you for that great introduction and happy Friday, everyone. And also thank you for that great overview of the social determinants of health and how they impact the treatment of obesity. Like Dr. Franklin said, I'll be discussing how we define food and nutrition insecurity and strategies to assess and implement appropriate interventions. We all have a responsibility and role to play in the assessment and evaluation. However, and I want people to chat or type in the chat box for me. The Academy of Nutrition and Dietetics states as registered dietitians, we're uniquely positioned to lead and support the development, implementation, and strategies to improve food nutrition insecurity. Thank you for already posting in the chat, Glenn. So that being said, during your dietetic internship, hopefully there's some dietitians here today, did you receive more than 2 weeks of training in a food or nutrition insecurity location, something like WIC? Did anyone get more than 2 weeks or 1 week? Don't be shy. Nope, worked at the VA. Oh, hey, Beth. No training, and you did. Awesome. Okay. Well, I only got my 2 weeks. And so I think it's so crucial that everyone is here to pick up this information. This is an ongoing education tool as well. So hopefully we can all get the team involved and share this together. So like Dr. Franklin was discussing the social determinants of health, as we know, access to nutritious foods is a critical determinant. And food insecurity, which means having limited or uncertain access to adequate or nutrient-dense food, is associated with poor health outcomes and higher odds of chronic illness, similar to the treatment of obesity. It's so important that the nutrition is addressed under 2 domains: economic stability and neighborhood and built environment. Now, why this is helpful, this is an excellent resource to see what the current objectives of the Federal Nutrition and Waste Status Work Group are working on and what initiatives have they already started to put in place, because we can use some of those too in our own clinic setting. Nutrition and food insecurity have a significant impact on obesity, creating a complex and often paradoxical relationship. Where there's a lack of access to food for individuals, oftentimes they're forced to choose calorically dense, convenient foods. And there's even metabolic changes where the body becomes more accustomed to storing food, or more accustomed and efficient at storing fat. This also impacts our mental health, potentially leading to unhealthy coping strategies. If you can't afford to take your family on vacation, you may be able to afford to take them out to eat or pick up fast food on the way home. And so how do we work around those coping strategies as well? But before we do that, we're going to do the definition of what category an individual may fall under. Nutrition and food security is not created equal. So the USDA has outlined it in a few different ways. So high food security, I have absolutely no issues or anxiety about my access to food, versus very low food insecurity, where I may have disruptions in my ability to get food, or there's a time period where I can't get that nutrient-dense foods due to cost or lack of funds. And then everything in between, where I may just have anxiety about where my next meal is coming from, or I have to reduce the quality. Now, according to Feeding America, food insecurity has risen from 11% in 2017 up to 12.8%. But more than a percentage, I'm a big number person. And so an estimated 15 million households currently have a prevalence of food insecurity. And just like obesity, there's a stigma associated with it. So not a lot of folks feel comfortable talking about, I may not be able to provide for my family this month. So we want to create safe spaces so our patients feel comfortable discussing this with us. How does this impact the overall healthcare expenditures? Because it's more than just nutrition at the end of the day. So again, if I'm trying to decide if I'm going to get groceries, and next slide, please, Dr. Franklin. If I'm going to decide if I'm going to get groceries for the next couple of weeks, or am I going to buy this medication or vitamin that's going to last me for the next month, I'm most often going to get the groceries for my family, right? Because I'm just one individual in that family dynamic. So I'm going to have poor medication adherence, which leads to higher rates of diabetes distress, risk of poor mental health, and management of other chronic diseases, ultimately leading to more hospital admissions. Therefore, forcing folks that have very low food security are spending 24.8% higher amounts compared to someone who's food secure. Food insecurity is currently adding $53 billion to our deficit each year, our healthcare deficit. And as you can see, individuals dealing with very low food insecurity across the board are going to have higher rates of weight-related issues as well and other chronic diseases. And the important takeaway from this slide is food insecurity is often inconsistent throughout the year. It fluctuates with changes in employment, seasonal work, and even economic conditions, which means when someone comes into the office, we're not just going to assess them one time. We're going to assess them pre-op, post-op, and any time that there might be heightened periods of concern. We're going to ask these questions. And the good thing about asking these questions is it's only 2. So the hunger vital score, or vital sign, excuse me, identifies households at being risk for food insecurity. And that's on the next slide. If they answer either or both of the following, so often true or sometimes true, this individual is suffering from nutrition or food insecurity. And this is a very easy way to include this in your EMR. This question is oftentimes included among other social determinants of health screening tools, and we'll put like a little nice emoji on the chart so that way the entire team knows that this is something that we're working on and trying to address. So back to the chat, does anyone have the hunger vital sign score on their EMR already? Yes, yay, good, awesome. I'm happy you've already implemented it. All right, next slide. So and the reason why this is so important, because the presence in weight management and bariatric programs tends to be a little bit higher, and forgive my typo. So Brown et al. Surveyed 298 participants located in North Carolina and Ohio between May and July 2017. One of their inclusion factors was the individuals had to be residing with their child or romantic partner and participating in a bariatric surgery program or a medical weight management program. And what they found was household food insecurity at HFI was present in 29.2% of adult participants. Anybody happen to remember what the national average was or percentage was? It was 12.8%. So the scary thing about this as well is it was present among all incomes and education levels they found. Statistically different it was most prevalent in households with 3 or more children. And again, it was at a higher rate compared to the national average. Brown et al. Recommended additional research, but hypothesized that the higher rates may be due to the fact that we're asking a lot of our patients, right? This was a tough pill for me to swallow. We're asking them to improve their diet, which means purchasing fresh produce, adding vitamin supplementation and meal replacement options. So yes, we are actively trying to improve lives, but we also may be introducing food insecurity into the household. So other than households with greater than 3 children residing, other risk factors include distance from the grocery store. So I live in a great neighborhood in Midtown Atlanta. My closest grocery store is 2.4 miles away, so I do live in a food desert. I Googled how the bus route, it would take me an hour and 13 minutes. I would have to make a transfer. And I don't know if you've ever rode the bus, but a transfer is like the worst thing that can happen to you, because then I have to carry all of these groceries back and wait at a different bus stop for it, right? So distance to grocery store has a huge impact. We'll see it in predominantly Black and Hispanic neighborhoods have fewer large chain supermarkets as well as rural areas. And then because there's just fewer large chain supermarkets, individuals are having to spend more per dollar on access to these fresh fruits and vegetables. So again, we want to look at we're assessing everyone, but especially those that are higher risk or further away from a grocery store. We definitely want to be asking these questions as well. Now, past the doom and gloom, here are some strategies that we can start to implement to alleviate some of these concerns for our patients. This is on a national level and also a local level, and Janée will do a great job about talking about some of these items as well. Some of the more popular ones are the GUS Nutrition Incentive Program, formerly known as the Food Insecurity Nutrition Incentives Program. That, along with the REACH program, gives grants for competitive projects to help low-income consumers access and purchase fresh fruits and vegetables to help prevent chronic diseases. So this is something that you can look up who received these grants in your area and work with a partnership. Now, if you look to the map to the right, this is from the Food is Medicine Coalition.org. These are all areas where there is either a food prescription program or a medically tailored meal program. So a produce prescription program is an individual's receiving fresh produce directly to their house. The only tricky thing with that is if they don't have the equipment to prepare it or if they don't know how to. So education for that can definitely take place in clinic. Medically tailored meals is definitely one of my favorite options because imagine you're getting discharged from the hospital, you have your medical prescriptions you have to take, maybe you're going to physical therapy or outpatient therapy. And the last thing you're going to think about is, well, what food am I going to eat when I get home? Let's just stop by McDonald's, right? Well, medically tailored meals are oftentimes covered by your insurance, even Medicare and Medicaid. And they will deliver pre-made meals based off your specific diet prescription to your house. So that's been a really rewarding program for my families. That way, if they're having to purchase additional meal replacement and vitamin supplements, they can get that extra support through food. And yes, just like Beth said in the chat, SNAP is also a really great benefit. They cover protein and meal replacement shakes. They can even use that on Amazon delivery. So if they don't have access to get to the store, they can use their SNAP benefits for that. One problem I was running into post-pandemic is a lot of those benefits ran out and folks were now making a little bit too much to qualify for SNAP. And so I would pair them with the food emergency program. And that was like a little bridge to help them in between. Next slide, thank you. Partnerships are so big and collaborations are so big on this. You know, you wanna work with your support group and other patients with this, right? We oftentimes work with sharing. Like if I've purchased a lot of this meal replacement shake and I just don't tolerate it anymore, having a donation program set up can be really helpful. Working with bariatric vitamin companies to request additional samples, or oftentimes if you go directly to their website, they have specific programs that can provide supplements at either a reduced cost or free cost for participants that may be having some economic strain. But we want to work with these grant programs. We want to reach out to universities who may be having these already established produce prescription programs or medically tailored meals. And that's just one thing that we can take off our plate and improve their participation rates as well. For direct links for some of this information, the Food is Medicine Coalition, here's their website link. Again, you can do the medically tailored meals or also produce prescription program. Mom's Meals is also a national program and it's covered by Medicare and Medicaid. And then if you're looking for more information and strategies, the Food Research and Action Center and Feeding America have a lot of great information as well. But now we get to see boots on the ground or hear about boots on the ground. I'm going to turn it over to Miss Janée about how she has impacted her community.
Thank you. And thank you for this opportunity to present with you guys. You know, I love what's happening in the chat. And so it's really great. I think you guys queued me up well. I'm just going to give you an overview of the Mid-Michigan Community Health Access Program and our partnership with the McLaren Flint Bariatric Institute. And our goals to just wrap our arms around individuals and meet their health-related social needs so they can really be healthy overall and better achieve health. So CHAP is my favorite. It's a collaborative, community-based, family-centered medical home improvement program. And really what that means is that the team is comprised of people who live in the community, are of the community, and have sort of a really deep awareness of the resources that people need and have the ability to build rapport and get folks connected to those resources. So we have a few goals in CHAP to make sure people have a strong connection with their PCP, that they're going to the doctor when they need to, and that they just don't have any barriers preventing them from adhering to whatever the doctor is telling them to do. So I think of it as taking like a population health management approach to social care coordination. So you guys are at the clinic, likely screening for needs, but then what? This is where CHAP comes in. So we are across like 21 different counties at this point. We commonly call it Janée's version of Mid-Michigan. So you can see our reach here if you guys have an interest in partnering. But if you don't have, if we aren't able to serve you, I'm sure there are other local agencies or community partners that you can find close to you to help meet those needs. Next slide, Dr. Franklin. Thank you. So I really don't have to say much about this. You guys have, been, going in the chat talking about the health related social stuff. And you can see here, the reason the CHAP was created is because we realized that really what makes people healthy and happy does not happen in a clinical setting. So our program was created to really address that other 80% that people need to just get better about addressing and improving their behaviors, that we need to help get folks connected to resources in their community, and really advocate for systems level change in order for everyone to be healthy and have what they need overall. So if we go to the next slide, I'm just going to tell you a little bit about how our program works. So CHAP aims really to accomplish its goals at various levels. So we work with clients and families directly. We have strong partnerships with our provider partners who can refer people to us so that we can help make sure they have what they need. And most importantly, I think not maybe most importantly, but underlying, we really need to start working at the systems level. So for example, one change that CHAP was able to get implemented in our state or in our Genesee County is that there's no longer 72 hours required to book Medicaid health plan transportation, because we realized after working with clients and providers that people just couldn't meet that need. So we were able to reduce that down and advocated for a systems change. And now you only have to have 24 hours notice. So we're still working at systems levels all the time. And I think our partnership with the McLaren Flint Bariatric Institute is going to help us advocate for some systems level changes like the things that you guys are talking about in the chat. So if we go on to the next slide, often people are like, well, how the heck are you guys funded? Honestly, it's a variety of things. Just like, you want to have diverse funding streams to be wealthy in life, you kind of want that too from the community-based nonprofit standpoint. So we've been able to advocate, write, and receive a number of different grants at the federal level. There are some that we get from the Centers for Medicaid and Medicare Services, and also HRSA and other things like that, the big behemoths up there. And then we also have some statewide grants or appropriations that we were able to sort of write and receive and ask for additional funding. We also get grants, I would say, from our health plans as well. So Blue Cross Blue Shield, they also fund M-Shield, like Dr. Franklin was talking about earlier today. So you kind of got to mix and braid what you need to get things done in the community-based space. So we've also been able to advocate for local funding. And I can't stress enough how important it is to advocate for policy changes and leaders to appropriate dollars to agencies and programs like ours so that we can meet the needs of those who have them. And then the last thing that I think is really critical for you to know about funding programs like ours is that we have relationships with most of the health plans that operate in our coverage area. So we're able to contract directly with the health plans to provide community health worker services based off of our agreed upon scope of work. So this is a lot, but this is a good example of these are the various options you can consider when you're thinking about ways to build a program like ours. So this is primarily how it works. So we are a clinical community linkage hub, which means we sit in the middle of our clinical providers, hospitals, and specialty clinics. And then they are screening for social determinants using the tool that Dr. Franklin shared earlier. We developed that from a community standpoint. It's really key to make sure you're tailoring your social determinants of health screening to your community. So for example, in Flint, we ask about if folks have access to clean water, because everybody knows in Flint, there was a water crisis and we need to make sure folks have what they need. So those individuals who are screening for social determinants of health at the clinic will then refer to CHAP. Usually it happens via fax or something like that, but I really don't care how it comes in as long as it gets in. We enter it into our system, and then we are referring and connecting the right care coordinators, the person that can help meet the needs so that they can reach out to the clients and then connect them to resources in a closed loop manner. So we like to make sure people that have needs actually get them. So we use technology in order to leverage that. So if we go to the next slide, I think I'm just going to now talk a little bit about sort of the outcomes. I think you see here, and you heard on this webinar today, food is a big deal. You can see those individuals who were referred to us from our friends at the McLaren Flint Bariatric Institute primarily needed access to food, and that meant supplements, protein, all sorts of things. There was just a lot of folks needing food. You can see the next thing, people are struggling with housing. And then the third orange bucket, that's the biggest, is transportation. And this is quite consistent across our program. So I'm just speaking a little bit about, there were 81 individuals who were referred to CHAP, but this is what we see in the thousands of individuals that we serve. So we're able to see that this model can work even for our specialty populations. So if we go to the next slide, I'm going to talk a little bit about what we were able to do with that. So you can see here that we really like to make sure that individuals are really breaking out and they have everything that they need. So you can see stress, depression, anxiety. These are all of the things that are happening. Now, the first slide gave you that there were 81 individuals referred to us, but those 81 individuals had almost 300 unique needs. So when we get them in the door, we are uncovering much more that you might not see, right? So health-related social needs are everywhere, but sometimes even when we get them into CHAP, we uncover more as we're building relationships with individuals. We go on to the next slide. I think it's important to really talk about our outcomes. I think this might be a duplicative slide. Did we go forward, Dr. Franklin? There we go. Here's what I like to talk about. You guys are like, well, what is happening, right? We're screening people for social determinants, but are we actually doing something about it? And you can see here that most of the time when we're able to reach an individual, we're able to resolve that need. So that person comes in the door needing food, and we don't close them until we've resolved that outcome. One of the things that we are able to do in CHAP, because we have a few diverse sets of funding streams, we were able to buy some of the protein that folks need and actually deliver that to them. So we get a little bit creative, but we try our best to make sure we're resolving the needs that individuals have. Sometimes people just don't want our services, even though they may need us, or it's difficult to reach individuals. So you can see here that it's not always a positive thing, but when we're able to reach, we do our best to make sure we're resolving that need. All right. And I think that might be my, okay, one more slide, I think. Let's see, I do want to talk a little bit about the outcomes as it relates to everything. No, I did that. All right, and bouncing back to Dr. Franklin to wrap us up. Thank you, guys.
Thank you so much. One of the things that is so impressive to me is that with Janée's program, they have a resolution rate of concerns that is well above 50%. And so often we are not able to have such a stat in regards to resolving those social determinants of health. The other thing that her program has is she doesn't lose a lot of people to follow up. And I find that to be amazing, but I think it is a combination of the relationship that she has with us as providers, as well as the relationship she has with the patients. The patients feel like addressing these social determinants of health is just part of their care. It's just another step in their journey to get weight loss surgery. They don't feel like it is something extra. And so they have been more than willing to follow up with the phone calls or text messages and getting the resources that they need from various agencies. The feedback that we get is, you guys actually care about us. Like, we are not just a number to you. And that kind of experience in a healthcare system creates a place of safety where people want to continue to come back and see you for their needs, where they trust you to talk about what's going on with them when they may not have even told their family what's going on with them. Our goal really is to create a bridge so that we are able to take care of people and meet people where they are and help them get the care that they need. So we're building that bridge to better health. And anytime you look at talking about achieving health equity, you're really going to have to focus on structure, process, and outcomes. And I can't tell you enough how Janée has helped us with outcomes. The data that they collect and are able to present back to us in this various chart, we're then able to take to our executive team and talk to them about, hey, this is what doing these things helps for our community, which has helped us in other spaces generate money to participate in health fairs across the community. Just this year, we have doubled the amount of health fairs that we've got funding for prior to previous fiscal year, in part because of the data that I've been able to show them from Janée's program about how this is having an impact. And I take Janée's data along with the data I showed earlier from Dr. Varban and Dr. Ferguson to say, okay, even though we are in some of these deprived areas, our outcomes, at least 30 days, are similar because we're doing these extra things. It doesn't just happen. We've got support out there. Let's access that support, connect our patients, right? Be that bridge for our patients so that they are able to get what they need. So again, thank you guys both for presenting today. You've given some wonderful information. Casey has given us some wonderful websites to go to help address some of those food insecurities that we are seeing. And those sites are applicable across the nation. I know a lot of what me and Janée talked about is Michigan Flint specific. Casey has provided information on a national level that will be able to be helpful for you guys. So if you have any questions, please don't hesitate to put them in the Q&A box that we have down at the bottom, and we'd be happy to take any of those from you.
We do have a couple of questions. Somebody was asking, how do we obtain a copy of this? I'm assuming that you're referring to the presentation. And so the presentation is recorded and it will be posted on the ASMBS website, if I remember correctly. On their YouTube, I think is what James was telling us. So this is being recorded. Couple of other questions. It says, has anyone had success getting a prescription for meal replacement on state Medicaid?
So Casey, I think that would be a great question for you.
I haven't had any luck with the meal replacements. My best luck is working with other dietitians in my area and going to our Georgia meetings and discussing what they're doing for food nutrition insecurity, because thankfully we have programs like Open Hand and the Ryan White program that will provide additional supplementation. So that's been my luck, but writing a prescription for them or requesting the doctor to hasn't been, unfortunately.
And somebody was asking about is the question that the insecurity. It says, what do you do with the question after the patients answer that they have a food insecurity?
We don't have an amazing Janée in our clinic. So we developed a handout, and it's thick. It's like 50 pages. Last they updated it. So we also have a QR code that they can just take a picture of and have access to things that are in their area and links and phone numbers once they respond yes. And then of course, like asking them what they're comfortable with. Standing in the line for a food bank is not always the funnest thing to do. So opening the door to additional resources, like knowing them about our support group program and things things like that that they may be able to use first.
It says, my experience with SNAP is that they only cover Insure. Have you guys seen Insure cover with other brands?
So feel free, anybody else, to answer this.
So Casey and you.
They don't cover supplements, but if it has a nutrition facts label on it, most oftentimes a SNAP will cover it. So educating patients on the difference between those, and then making sure, of course, that they have enough vitamins to cover the extra supplements that they may need.
So Casey, I'm going to do a backup question to that. So nutrition facts, so Premier has nutrition facts, Fairlife has nutrition facts. Have you seen those cover those particular products as well?
I've seen them cover Premier, Pure Proteins to get covered. Okay. Most of the things that you can find in the Walmart protein section, they're pretty good about covering.
That's great.
Any other questions that you all may have? We got about...
Sorry to interrupt you. I saw Carly's question about the people not knowing. Yes, food nutrition knowledge is like a huge barrier. Oftentimes people are coming in and they're like, I've never cooked anything. I'm just throwing things in the microwave. So have fun in support groups. Do a cooking demo. We'll send out like a pre-approved grocery list to everyone. Make sure that it's something that's affordable, less than $10 for a family of 4. And then we get all together on a Saturday virtually, and we're all in our own kitchens cooking together. It's really fun. So please do that, Carly, if you have a chance.
The big thing I find too with education is informing them about how all sugar isn't good sugar, right? And they love to make smoothies, and the smoothies tend to be made with coconut water or pineapple juice or 2 or 3 cups of fruit, and trying to just get them the knowledge that although those items are all healthy in their own right, and the combination of them can create a situation where you're dumping or you're not seeing the weight loss that you want to see. So I think that kind of goes back to the one, if they don't cook often, right, that seems like an alternative, making the smoothies, but making sure that they understand the actual nutritional value of the foods that they're choosing and how combined together that has an impact. And so we spend a lot of time going over those kinds of things with patients in regards to how to use their apps to track those things, because I have a lot of patients that don't do so well in math. I have a lot of patients that experience dyslexia. So we really do try to make sure that we are addressing all of those various gaps, but we don't know about them until we start talking with the patient.
There was a comment about a grocery store tour. We've done that with one of our dietitians as a support group. And so we contacted a local grocery store, just getting their permission, letting them know that, what it was focused on. And we kind of set up a time, and then we advertised to our patients that instead of meeting at our regular location, we would meet at this particular grocery store. And then the dietitian just walked them around and explained, what were they looking for when they were in the grocery store, that type of thing. So I hope that helps whoever was asking about the grocery store tour.
Yes. And if you have too much on your plate, a lot of grocery stores now have like minute clinics in there that will already have a dietitian who already does the tour. So you just have to contact him or her, and then that's one less thing you have to worry about per group.
Any other questions? We got about 5 more minutes.
I have a question for the chat again. Do you have any patients that demonize canned food or frozen food, but then will choose fast food? Does anyone else have to deal with that? Back to education is so helpful and important. It's like canned food, it didn't do anything wrong to you. You're okay.
One of the things I will say is I never saw a death certificate that had cause of death canned food.
Hey, that's a great answer.
I've never seen it. Oh, it's a lot of things going on.
It's how did you get patients interested? I'm assuming like interested in the grocery store or interested in the program. I'm not quite sure.
I'm not even.
Jerry, what you were inquiring about. Grocery store, okay. And we just advertised it as part of one of our support groups. Right, like I said, it was kind of like a field trip that we all took to the grocery store. And so instead of doing just our routine support group every month, we just moved it to a different location. We've done that. We've also done like a group walk. Like moved it to a local park and did a group walk to kind of just help engage them. And then it occurred in the evening that we typically hold our support groups. So we hold them at 6 p.m. And so that's whenever we did the tour.
And now
and how did you make the initial connection or contact with CHAP?
So Janée, you want to take that one?
Yeah, sure. I think our program is about 10 years old now. And so we initially convened a variety of stakeholders in the development of CHAP. So we had a relationship with McLaren Flint at large, like the entity it was easy to sort of make the connection specifically with the bariatric clinic, but we were funded through M-Shield, like Dr. Franklin shared earlier, and that's kind of how it sort of pivoted to more specifically helping individuals with bariatric surgery. So funding kind of got us where we are, I'd say.
Mm-hmm.
All right. Well, I don't think we have any other questions for our panelists. I want to thank you all for joining us today for lunch, and thank our panelists as well. We really appreciate your time, your effort that it took to put this presentation together. It was a great outcome. So thank you all for attending, and you all have a great day.
Thanks, everyone.
Yeah.